And I want to begin saying I read a very interesting health affairs blog a week or two ago that was talking about tapering of growth in ACO contracting. And this, I forgot who the author was, and the author may even be in the room, was describing it as a tapping out of the pioneers, of the organizations more attuned to being pioneers. And because we don't have a lack of a proven model, not yet bringing the followers in. And that's just a way of introducing where I think we are. There's been really a very large amount of Medicare activity, a fair amount of private plan contracting with providers as well. But turning first to the providers, what are the challenges that are uppermost in their mind when they look at opportunities to contract with plans on an ACO bundle payment medical home basis?
Sure, I'll be happy to take that. So the first challenge when a provider system or when a provider seeks to undertake risk in any model, be it a Medicare ACO or even a risk-based contract with a private insurance company, is to, first of all, understand whether or not they are a system. Do they control, either physically control through ownership or virtually control through contract, enough of the continuum of care and the environment in which care is delivered to be able to undertake that risk? The second thing, and it follows on very, very quickly, is do they really understand what the cost and utilization trends are within the population that they envision taking risk for? And that's, after considering those two elements, most provider systems stop. Many have data, but they don't have analysis or analytics. If they have analysis and analytics, they are not truly systems, because when I was a young, bright-eyed analyst, we were all talking about integrated delivery systems, very few of them actually got built. Or if they got built, they got disbanded. And that's part of the natural process of build it up and contract into one entity and then expand like a beating heart. That's what happens in my space. So that right now we're kind of at a mismatch. There's a demand for, on the part of hospitals, they are actively interested in taking risk. And it's not just the hospitals. In fact, we have a home health company, Amedisys, which claims to be wanting to manage the entire post-acute spectrum of care for bundled payment networks and other at-risk arrangements. So those are the things that they start looking at first. If there is a system out there that is enough of a system or can construct enough of a continuum, including physicians, which is a key element of this, and they feel that they have enough of the data, then the question is, do we really understand how to underwrite risk? And I think it's a little bit flippant to say, well, all they have to do is hire actuaries from the insurance companies. There's a lot more to it than just that. But there clearly have been some systems that have said, yes, we have all the necessary elements in place and we can do that. And I'll go back to Detroit Medical Center, the one that comes to mind as having been a pioneer ACO. Clearly they believed that not only are they an inner city and somewhat integrated medical center, they're an island in Midtown Detroit, they are also affiliated with Wayne State Medical School. And they have a very sophisticated electronic health record and clinical information system, and a very sophisticated approach to evidence-based best practices. So, those are, I think, some of the elements. It's very difficult for hospitals to successfully take risk. It is a behavior that is not natural to hospital administrators. And it's not just the taking of the risk, more importantly, better said, it's the managing of the risk once you take it. So I get very nervous when any of my companies tell me that I'm a provider and I'm going to be a leader in taking risk. I think there are a few systems out there that can do it. I think they're few and far between, and I don't think that's going to change for a very long time.
But Sheryl, let me ask you, do you think, and you touched on it, because I think one of the big changes now is IT, and we hear a lot that being able to understand and manage sort of the clinical care as they build up those databases, that over the longer term, that they'll be in a better position for a given patient population to maybe make that transition into taking on more risk. I mean, currently right now, they just don't have the depth, and we hear a lot about big data and mining that, partly to take out the variation in clinical delivery, but also as they build up that patient population.
Yeah.
But they just don't have the loss data, and obviously the insurers, there's no way they're going to give that up.
Right, or if they have it, they haven't converted it into something that they can actually use to understand the trends and then price and mitigate the trends. One interesting development, though, that kind of gives me hope in this direction, HCA is a very large organization. They have over 30,000 beds. They have millions of patient interactions a year. They have tons of data, whatever the big number of data is. I'm not a data person. But they have a data warehouse that they've now just constructed. They are building additional patient data centers for some of their customer interactions through Parallon, their GPO/revenue cycle management company. But they're doing a lot of things now to really focus on building up that data warehouse and then moving beyond that to mine that data, as you suggest. And they are a large enough scale organization to be able to ultimately, if they do this right, compete with any managed care organization in terms of their ability to understand trends, price them, and risk them accordingly.
Yeah.
And I think you need that kind of scale if you're a national health system. Take a Tenet with 50 hospitals versus an HCA with 160 hospitals. I think that HCA is much easier. It's easier to see HCA being successful at it than Tenet. However, what they are doing is there is a willingness to take risk on a sliver of a population. So, for example, if you're dominant in women's health in a market, you might actually take a risk contract to handle every single maternal child health case in your service area, and would probably want to do that.
Yeah.
Because if you're the dominant provider and you're seeing these patients anyway, you might as well take a piece of the risk return.
Right. And I think one of the other things that's going to be interesting is obviously in the not-for-profit space, we've seen the FTC come in and block some mergers. And part of what we want is better scale and better efficiencies out of better size, but there's also some regulatory and legal roadblocks, because I think as organizations look to take risks, it's not having size and scale, but it's also having focus and presence in certain markets. And right now, that's a big question mark.
Yeah, it's not the first time that we've seen antitrust policy not be aligned with payment policy, and probably won't be the last.
One other factor I want to throw in on the Medicare ACO side is, my anecdote was a couple months ago I spoke at a meeting of 60, 70 ACOs that are now members of a new National Association of ACOs, and we were talking about the weakness of the shared savings upside-only model, and when we were going to go to two-sided or maybe even something stronger than that. And but basically the question the moderator asked the crowd is, how many of you are interested in taking risk? And basically the answer was 1. And that was, and what became real clear is that a retrospective assignment approach to determining who you're taking risk for is not compatible with taking risk. And they all said that. We don't know who we're taking risk for. It affects all the stuff that's going on all year until CMS decides that you were taking risk for that person. The patient goes to the hospital doesn't know that this ACO is responsible, et cetera, et cetera. So I just don't think we'll go very far in the Medicare context until we change that retrospective assignment model. Clearly on the commercial side, it's not the same, and there's somewhat more risk-taking. The other observation I would make is that there are more physician ACOs or would-be ACOs than I had expected. It's not all dominated by hospital ACOs. That even exacerbates the problem of management and scale and all that stuff. And so relationships between physician groups and insurance companies. Universal is one that sponsors more than 30 ACOs right now. So there will need to be some mechanism for supporting both financially and with managerial know-how physician groups who want to take risk. I mean, the advantage they have over the hospital is that probably the earliest or the lowest hanging fruit is keeping people away from the hospital.
That's right.
And so that's in some ways, and I think the early results from the alternative quality contract in Massachusetts is that physicians begin to get some leverage over the hospital and can move patients and get some negotiations over prices, by moving patients from the Brigham to Deaconess Beth Israel. Not only did I think it was Atrius save some money on their ACO contract, but they got Brigham back into the game of bringing their rates down a little bit. So the issue there is Paul and I contributed to an article about the California situation. Do you move sort of monopoly pricing down from the hospital to the medical group? Is, I guess, the question that happens if you have a dominant medical group in an area, but I think there's probably more competition on the physician side than, at least in some areas, on the hospital side.
So you mentioned the business about the retrospective. When the regulations first came out, the title of the report that I wrote was, "We must be missing something," because we can't understand how any rational provider would ever sign up for this this model that was sure to lose them money. And part of the other interesting thing was that managed care companies were specifically excluded from the Medicare ACO model. They cannot be a part of it. You can only be a provider to be in a Medicare ACO. And yet all of the experience and all of the knowledge and understanding and data, quite frankly, on managing risk and undertaking and all of the knowledge and learning and actual practical application of managing patients and directing where they go resides with the managed care companies, or at least allegedly resides with them. And they were specifically excluded. So I sort of stepped back as being a Wall Street person and not being an inside the Beltway person and say, what on earth were they thinking? Who was going to join up? I was shocked that there were as many pioneer ACOs, and there was as many ACOs who signed up. Now, the final regs were somewhat mitigating some of those issues, but not nearly enough. And so, yet again, another missed opportunity to maybe innovate in some way to build a better quality, lower cost system.
Bob, on this issue of retrospective assignment of patients, do you think prospective assignment would be enough, or do we need to really start thinking about enrollments?
At the very least, you need to have sort of in Medicare a PPO kind of platform where you have benefit design incentives to where you do somewhat better. I mean, the issue there is you have to work then with the supplemental wraparounds and actually have that incentive play out at the beneficiary level. Ideally, I think we should be moving into the direction of enrollment. At this point, you really, in traditional Medicare, can't talk about limiting choice. But I'd start with benefit design and maybe move towards a kind of... I mean, it's interesting. Some countries in Europe, France, I know in particular, has moved to what they call a soft lock-in. You can go to a specialist, but you have to designate a primary care physician, and some citizens have changed their care-seeking behavior by first going through the primary care physician, but it's not a formal gatekeeper system like a number of European countries have. I think we need to sort of think about sort of a middle ground between a firm, I am a member of X health plan and I'm locked into that network, and full freedom of choice, which is, in some areas, if you're Geisinger or Scott and White, it's probably pretty good to have full freedom of choice because you're going to Geisinger and Scott and White.
That's exactly right.
In Boston, it's not the same situation, and so I don't think we've spent enough time thinking through how we sort of balance the desire for beneficiary choice, but the need for an organization to know who it's responsible for and to have an alignment of the patient and that organization.
You don't save money unless someone in the system is accountable for the spending of
Right.
money.
Right.
And in an ACO, there's no one who's really upfront accountable and therefore having the incentive to take rational actions.
And as we
to
were
make sure
talking
that
during
it
the
saves
break
money.
with, I'm sorry, what's your name?
Alexa Page.
Yeah, okay, so we were talking about an orthopedist. If an orthopedist is in an IPA or a PHO and is still getting fee-for-service revenues, and so I can either do I'll take some liberties here, my unnecessary hip replacement.
They're never unnecessary.
And get full reimbursement, and the ACO won't do as well, or I can get some infinitesimal share of some shared savings in 2 years if if the organization, which I barely know exists, hits some threshold. You don't change behavior. And so I don't think it's actually surprising that the physician group practice demo sites didn't bring in the orthopedists and the cardiologists and all of those people and say, we don't want you to be generating the services you're generating to the hospital. They tried to put in congestive heart failure programs, did some things at the margin, and that they wasn't huge success. I mean, because I think that I understand the arguments that you got to take baby steps and all, people don't want to take risks, but I would have mitigated the risk with risk corridors and things like that, but move to actual risk bearing with a prospective, at least assignment, and ideally moving in the direction of an enrollment rather than what they came up with.
Why don't you just have provider-based Medicare Advantage?
Yeah,
Well, we called that provider-sponsored organizations. We had negotiated
and that worked too.
rulemaking in the 90s, and 3 showed up in the history of the program.
Yeah.
It's
But if you did it with the but I mean, that's essentially what you're arguing. I mean,
Yeah.
this is trying to do managed care without the managed care entity.
yeah.
And guess what, guys? It's not going to work. Somebody's got to manage the care and be responsible for the risk.
Yeah,
And with that comes limitation.
But in California, you do have at-risk capitated medical groups who put in a managed care structure.
And they're regulated as insurance companies.
Well, that's exactly right. So I'm just
They
saying.
are insurance companies, which is my point.
Okay.
Yeah, I
Fair
would
enough.
agree with you.
I was going to say, I think, what we heard is with the Pioneer ACOs, I think Banner down in Arizona, they put a lot of time and effort into it, and the fact that those patients couldn't be attributable to them, and even if they were to get some benefit on it, I was surprised how, all the work and time and effort that went into it for very little upside. To me, sort of made me scratch my head. So I know Banner sort of looked at it and just said, without being able to attribute the patients that are in our ACO, it doesn't make sense for us. And they got together with Aetna on an M.A. plan, and they said we like that a lot more.
Yeah.
Yes, I think that is a trend. Let me turn to the private plans. What's their interest activity in doing these types of contracts for under 65 people?
For under 65.
Well, actually, you could answer either way, or both ways.
Because I was about to jump into
Jump in
that.
Medicare.
Where I
Sure,
think
let's do that first.
you've seen the most rapid shift is in Medicare Advantage. I don't want to exaggerate it, but and it's happening faster at some companies than others. But they're clearly trying to. They're trying to downstream the risk where they can, because the risk isn't as good as it was recently, and we're going to be probably going through the toughest piece of the reimbursement changes affecting Medicare Advantage over the next 2 years. Now smart provider groups aren't going to say, oh, well, okay, now I'm suddenly going to take that percentage of premium from you, with the toughest 2 years coming up. But on the other hand, there are ways of getting incentives in place, shared risk, that does make sense to the extent it's going to lead to, assuming you're not compromising quality, to successful cost containment under this reimbursement. So there's a lot of activity. They're talking to it to a great degree on the commercial side, with some companies like Aetna using ACOs in shared risk arrangements to drive new market entry. But at the end of the day, what I can't point to is exactly what percentage of the commercial spending, let's say outside of California or even in California, is really moved to risk and is now in risk, it's still certainly the minority of spending. And despite all of this activity, maybe you know off the top of your head, Sheryl, but the percentage of the bed days that are paid for on a risk versus fee-for-service basis at some of the hospital companies, it's still overwhelmingly fee-for-service, to my knowledge.
Yeah.
But it's only in local markets. So Orange County, it stands out pretty much as the exception, especially for where the for-profit hospitals are. Sorry. Orange County stands out as the exception because that is where you have the largest capitated groups. And the biggest influence from them on the nature of the contracts. But ever since the late 90s when global capitation blew up in everyone's face, the hospitals have been very, very reluctant to enter into those kinds of contracts. And so, they much prefer to give their biggest customers, their biggest managed care customers, a price discount rather than take the risk. So it's still quite small.
Mm-hmm.
And I mean, I'd say medical cost trends, as we were talking about before, are at some of their lowest levels ever, at least from a rate of increase perspective. So managed care companies would gladly give risk to anybody who wants to take it at this point in the cost trend cycle. But as we've sort of touched on here, like to make this really work, you effectively have to transfer the underwriting and the actuarial capabilities from the managed care companies down to the provider level. And managed care companies have been doing this for 20, 30 years, and they still mess up on a very regular basis. So the idea that you can just transition this down to the provider level and everything's going to be fine, I think is a little short-sighted. The other thing is, we've talked about this need to take data and transition it into something useful. I think that's hugely important, and I don't think you should overlook how difficult that is. Think about Healthcare Partners, which is probably the most successful company taking risk, and you hear about just the excruciating process that they went through from sort of beginning to where they are now to make all this work. So I guess the example would be, it's one thing to have an electronic medical record. That's nice. It will tell you every health thing that I've ever had in my life, but it doesn't really tell you what to do. I think what Healthcare Partners and somewhat other successful companies have been able to do is, if you're a physician, you walk in the morning, you have a to-do list that's already been prepared for you. This person hasn't been in to see you in more than a year. Have somebody in the office call them and set up an appointment. This other person's prescription has expired. Call them, get it refilled. You need to have those action items to really make it successful, and getting that kind of infrastructure has proven very, very difficult to do.
If I just add one point to that, and having worked as part of a provider organization that did take risk unsuccessfully in the 90s, that I would venture to say it seems like the nature of the risk contracting has changed quite a bit from what it was back then, where there was perhaps a naive belief that this was not so hard to do. I think some of that had built on the early success of the model in California, where even in subsequent years there it proved tougher than it had seemed at the time. And also the managed care companies, I think, on their end were taking a simplistic view of, well, if we can get the provider organizations to take 78%, I once heard 72% of premium, and they'll have all the risk, and we won't, it won't be our problem anymore, and that obviously is is at one end of the spectrum. But today, it does seem like many more of these steps forward are truly partnership oriented, in the sense that putting aside all motives of the spirit of partnership, that at the end of the day, that certainly the managed care companies have a broader awareness that they are staked to the outcomes here, and they have to help the provider groups make it work, because if it fails, they're in it too, regardless of what the terms of a risk contract may say.
Mm-hmm.
So one of the things that put that into practice in conversations with United about what they're doing with they don't get along with hospitals too well. And I don't know that they get along with any provider too well, but I know they don't get along with hospitals too well. One of the things that they were trying to do was to work with the hospitals who did want to take risk in a very constructive way, I think the list of questions, when a hospital would come and say, we want to take a risk contract, the list of questions was 2 pages, single-spaced, back and front. If the hospital could go through that questionnaire and answer in the affirmative to all of those questions, then the hospital was essentially ready to take risk. And just by presenting them with, basically all of the necessary pieces that need to be in place in order to be a successful risk taker, made many of the hospitals step back and say, wow, we thought this was going to be hard. We know we're not ready. In some cases, depending upon the provider group, United will actually work with them, and I'm sure the other health plans are doing exactly the same thing. They will actually work with the provider group to get to the point where, say it was about 50 multiple point questions long for this questionnaire. If they could get to yes on 45 and they only needed 5 more, then it was in everyone's best interest to work on the 5. Mm-hmm. But it also places a burden on the plan because there's some services that the plan has to also provide that the hospital and the physician groups, typically we're aligned in this, can't provide. And so it has to be collaborative.
Good. Let me move on to network innovations. And one thing that came up a little bit in our first session was narrow or limited network products. And let me start by asking about, how are plans building limited networks? I mean, in a sense, what are they looking for as far as which providers would they like to have? Is it, how sophisticated are they in, assessing the value of different providers?
I can go quick. Price. I'm done.
Okay. But actually, how sophisticated is the price?
Sorry, how sophisticated?
How sophisticated is the price? Is it price per episode? Is it simply, unit prices?
Yeah, I mean, generally it's going to be the unit price or price per episode.
Okay.
Mm-hmm. Let me just offer, one thing that's happened. This is not quite to the tiered network strategy or narrow network strategy per se, but it's topical right now in that you've seen some of the health plans in Medicare Advantage taking some pretty strong steps to narrow their networks. Mm-hmm. On the physician side, it's been the most notable. In fact, there was there's been some communication about that. There was a letter that was posted yesterday from the health insurance industry to CMS, stressing how important it was for the plans to be able to make these network exclusions. But obviously for doctors who've been contracted in Medicare Advantage to suddenly be to be terminated, where in most cases they continue to participate on the commercial side, has created some real blowback.
Yeah, I had noticed that, Matt, and was wondering, it sounds to me that this was different of the way that a plan pursues a more limited network.
It is.
It seems as though, and I saw the Wall Street Journal article a week or two ago about United, and it almost seemed as though they were trying to get their star quality scores up by culling out the physicians who contribute to low scores. And is that what it's about, Matt?
Well, the truth is we don't really know.
Yeah.
That is from our perspective somewhat of a black box in terms of the decision making there. There are multiple criteria. There's how each physician group feeds into the star quality scores. There are utilization efficiency metrics that they can run on a broad, larger companies can run on a broad set of claims data. There's also, frankly, the consideration of which Medicare Advantage members are assigned to those physician groups. And, again, I'm not pointing to any one of these three as the factor, but, there you could have some, possibly some effort to change the risk distribution of the underlying membership.
So, just to put this in context, Medicare Advantage rates are coming down very significantly next year. They're actually going down next year from United's perspective, about 3.5% or so. And when your rates go down, some of your plans and some of your providers in those plans will have to be terminated because you need to essentially shrink to a profitable size. or a sustainable size. So that's part of what you're seeing is instead of the proactive, we're introducing a new benefit plan, we're going to build up a narrowed network. Now you're seeing the reactive effect of we have, United's always been a very inclusive and broad-based network. They've had some issues of, adverse publicity in St. Louis and some other places when they've tried to narrow the network based on quality. There's a lot less pushback on that sort of thing now. But they're getting some pushback on this one because, in Connecticut alone, for example, it's 2,000 providers. It's a lot in Connecticut. It's not that big a state. So, what you're seeing is, first, the unwinding. Second, I agree with you completely. I think it is absolutely a strategy to get their STAR scores up because they're a major embarrassment. And they're clearly, from their last conference call, a focus of the company's strategy of Medicare Advantage for the next couple of years is to get the STAR scores up. But I agree with Matt that there are many other factors at work, most notably that they need to get all of these markets where they've expanded rather broadly to get rid of the marginal plan, to get rid of the marginal provider, and in some cases the high-cost member.
But I think it's important to point to a major difference between the Medicare managed care situation and commercial, which is that in Medicare, out-of-network services are paid at Medicare rates. So that changes the whole leverage situation, and it's the reason I think that hospitals basically are in network at Medicare rates or near to Medicare rates because they don't have the leverage. Balance billing is a whole different situation. I'm actually surprised that MA plans weren't more aggressive in the past because they have that protection for the out-of-network care. In other words, there won't be such pushback from the beneficiaries hit with the complete balance bill if the physician is not in network or something like that.
Well, there won't be as much, but
Right.
we'll see as we get into that.
Right.
Yeah. So, getting into the employer-based, the commercial space, it looks like there's been a, both substantial growth in small group plans to have narrow networks, and of course, so many of the products on the public exchanges are narrow networks. And, any comments about, that strategy, how it's going? Is there going to be a pushback by the public?
Yeah, no, I think it definitely much more in small group and in the individual market than large group. So if you think about an employer like Citi, there's no way you could take what we have today and move that to a limited network. There'd just be so much disruption from that. I think it's much easier with a smaller employee population, particularly if you're the business owner and you can say, all right, well, our choices are we either go to a limited network, we don't have health insurance. Like, what do you want to do? I think it's a little bit easier to swallow that. So I think it is going to be much more predominant in the smaller end of the spectrum.
For a long time, the hospitals were telling us that while Wall Street was busy talking about the narrowing of networks, they weren't actually seeing it. It was only when the exchange contracts came up that even in the beginning, there was some concern that some of the contracts that were being signed weren't narrowed network contracts at the very beginning of the contracting. Towards the end of the contracting for reform, these are commercial, by the way, these are fundamentally commercial contracts. So by the end of the contracting, though, almost all of the contracts being signed were for some sort of a narrowed network. So I think there was a very quick evolution in the thought process of the plans in negotiating these things, where they very quickly realized this is one of the very few levers we have, we better pull it.
Yeah. And, to what extent, as they form these networks, to what extent are the savings going to come from keeping high-cost providers out or getting discounts from providers?
Yes.
Yeah. Any sense of which is the dominant piece, or are they both very important?
Very important.
Okay. Good. That's the answer I'm looking for. Good. Has anyone seen much tiered network activity in the commercial space?
Not in years.
Yeah, there's been less focus on that. That was certainly a topic that there was more discussion around maybe 4 or 5 years ago. I think as plans were looking at tiered networks as a way, perhaps of a gradual shift, more gradual shift to narrow networks. and still there's activity going on around that. I think one of the issues there is one simply of complexity, that tiered network is in between a broad network and a narrow network, and you have the A and B. But we'll see what happens. It's certainly an innovative approach that structurally makes sense. So we may hear more about that.
Yeah.
I was just going to add that one of the realities on the ground around tiered networks is the the must-have hospital systems that don't want to give concessions on price also don't want to be in a disadvantaged tier, and so the health plan might have an interest in moving to a tiered network, but they often can't pull it off because of resistance by must-have providers.
Mm-hmm. Yeah, Bob, are you familiar at this point about any states other than Massachusetts that have addressed that through policy?
I only know about Massachusetts, but we're going to be doing a survey of that, and for a project I'm doing with NACI, and we'll have a better answer for you.
Yeah. Now, reference pricing has gotten attention recently by what CalPERS has done with joint replacement, and they also do it with some outpatient services. And reference pricing is really, a more aggressive form of tiered networks. And do you see this as potentially important or very limited because it's never going to affect that big a piece of spending?
Yeah, I mean, I like it conceptually, but implementing it I think has been a challenge. So that's one major issue is that how many different procedures can you actually do reference pricing for? Sort of know what the cost is going in. And then I think the second is that it's a tremendous amount of work administratively to set that up so that you can have a situation where your employee can go to a website and know instantaneously, if I'm getting my knee replaced, these are the 4 facilities I can go to that'll be below that set price. And to do that for all of these different procedures, it takes a fair amount of work to get that done.
Mm-hmm. It does, although I would just say there's obviously an empirical, and you touched on this, an empirical appeal to that is something that we always sort of talk about. This is where we'd like to be, where you have packaged end-to-end pricing that you can compare price and if you have it, quality information across different provider systems. And so to the extent that is working to some degree, as I understand in California with the CalPERS demonstration, I guess you might call it, that I think that certainly seems like there'll be an attempt to take that more broadly.
Yeah, I think conceptually it's very appealing. The concern, I guess, that I have is it moves right now we sort of view with durable medical equipment and clinical labs as sort of commodities where you can actually try to negotiate on price because the product is pretty well standardized. It moves sort of clinical service into the commodity arena. Joint replacements, colonoscopies, MRIs are the ones that I've heard about. I think it puts a greater burden on on CalPERS and the others offering it to really develop the quality metrics that they can, at a much sort of service-specific level, not sort of prevention measures and HEDIS, but really, is this MRI meet quality standards? Their MRI, I got quoted in the paper about 6 months ago saying is an MRI, and there's actually a company in New York that doesn't believe an MRI is an MRI, and the equipment is all different. The fellow was telling me that in Japan they actually have different reimbursements for different kinds of MRI machines and CT scans, and then the quality of the so I think it's a good thing if it's accompanied by a real commitment to telling the beneficiary, the member, that we can guarantee a certain level of quality at this price, rather than, and I know CalPERS wants to do that. I think it does. So in addition to sort of the operational challenges, I think I'm adding another one, which is actually to being able to guarantee a certain level of quality and safety.
Well, and I think the whole idea of quality is something that's evolving, because how do you overcome the expectation, the reputational pull that most of us have about certain institutions. You can tell me all you want about quality, but if you're in Northern California, Stanford Hospital and Clinics is considered the best. Now, you may be able to show quality things, but it's hard to overcome those among patients that want to get the best care that they think they can get.
Good. Bob and I have, over the years, written a lot about health plan provider leverage, and just wanted to ask the panel if what they see as a current trend direction, in a sense, or is provider leverage vis-a-vis health plans increasing, or is it in retreat, or can't you tell?
I guess I'll just take a stab at this, and it's my sense that the provider leverage has been increasing more rapidly than in the plan side. Obviously, there's been a lot of consolidation on both ends, but I think what with the ACO concept, that has given some cover. Sorry, that's probably a cynical way of saying it, but I think what you have are hospital systems acquiring physician groups and other hospitals horizontally because it achieves multiple directives. One, it brings them closer to having the scale and the scope of capabilities to be a true accountable care organization, and that's great. But in the near term, it also gives them increased market power. And so to the extent that the ACO gives them cover to move in that direction and they can achieve both objectives, that's great. I think that's more of what we see.
I think it still depends on who you are and which toys you own in the sandbox. The more toys you have and the more attractive they are to the other kids, the more leverage you have, okay? So, but to put it in business terms, there are hospital systems with or without physicians attached in markets where you have a dominant Blue Cross Blue Shield plan who will never have pricing leverage. Health Management Associates is in a very bitter contract dispute in Jackson, Mississippi, with 10 of their hospitals having been, they felt they were getting insufficient reimbursement. They filed suit against Blue Cross Blue Shield, probably not wise given how dominant they are in the state. Something like 85% of all the small group lives go through Blue Cross Blue Shield at some point in time. And I think it's 57% of the individual lives, which I was actually surprised it was that low. And so, they're having a major contract dispute there over payment rates that the governor actually had to get involved and sign an executive order forcing Blue Cross to take the 10 hospitals back in, and then they threatened to sue and later rescinded it. So it's a soap opera. It's taking place and it goes on. But that's this is 10 hospitals that are, if not dominant, then important, especially on the OB side. And it didn't matter there because the payer is so dominant. In other markets, you still have dominance by the providers. I think that that leverage and that dynamic continues to exist. Where I think the health plans clearly lost leverage, I don't know what we were saying a year ago about what was going to happen to provider rates under exchange contracts, but my group 1, managed care group 0, it was, that's the score. The hospitals clearly won that battle. I think there are a few hospitals in Louisiana I know of for sure that are getting Medicaid or slightly less than Medicaid on some of their exchange contracts. And those are the only ones in the country I know of. There may well be others, but those are the only ones I've heard of. Everyone else is at or near commercial. So they won that battle pretty soundly.
And I would say, hospitals, I think, still have the leverage. WellPoint every quarter reports their cost trends, and they break it out by component between unit cost and utilization. Every single quarter, inpatient unit costs rise 5 to 7%. They're mid to high single digit. It doesn't really change. I'd say the one thing that has been a modest adjustment over the last couple of years is the giant hospital rate increases. So with a hospital would come in and say, I want a 60 or an 80% rate increase, and in years past, managed care companies would just sign. I think there is more willingness to push back on that now. Some of that may be related to the 10% rate increase threshold and some of the regulatory pressure that the plans are facing. But that's the only area where I can say I've seen any real significant change.
I would say among the publicly traded hospitals, the reason that you were seeing those was because you had a hospital system like Tenet that might have been subject to stress and therefore have below market rates in many of its markets. That's a nice way of saying going through a scandal where they overcharged and then they had to give money back. Okay, and so once you do that, you're kind of behind the 8 ball with the managed care plans, and then you have to go and beg for more money. So they did, but only after they fixed the system. In those years, you were seeing those kinds of 50, 60% increases in some of their markets because they had frozen their rates. But you're not. But I would agree with you. You're not seeing those kinds of things, especially among the publicly traded hospitals, because they've gotten to parity, unless it's in, and this is the real battleground that I see, the newly acquired hospitals, where the systems, whether it's a community or a Tenet or an HCA, especially if it's HCA, trying to get their pricing applied to either the physician group that they've just acquired or the hospital that they've just acquired. That's the real battleground, especially on the, we own the hospital, bought the physician group, we want this group to get the same benefit of our contracts, and the health plan says no. Then it all blows up.
Yeah, that's a good point, Sheryl, because I think before it was like, well, we'll bring this hospital into our system, and we're just, now they're at our rates.
Yeah, and the health plans are clearly pushing back now.
But I think over time, I think that dynamic, I think the hospitals, if you're looking at a teeter-totter, I think the hospitals are gaining more leverage, if you will, and more pricing power, just through consolidation. I think insurers for a long time have been able to take advantage of the fragmentation in the marketplace, and you're beginning to see some of the big systems in a place like Seattle. Boeing put their contract out, and they're looking to go direct to the providers. And I think as you see further and further consolidation, you're going to see more of that where providers are willing to go direct and sort of bypass the insurers for that function.
About the experience so far in exchanges, I think one of you mentioned earlier in the meeting that plans are in a weak position now because nobody knows which plans are going to have the volume.
Yeah.
And that it could be a very different situation next year.
That's right.
Yeah. Let me talk about hospital employment of physicians. And I've just been struck at how quickly this is moving, and just want to get started with really asking you, what are the really important drivers of this trend?
We've seen it. We've seen it a lot on the not-for-profit side, and I think it really is market by market. One of the credits I rate is Aurora, and they had a strategy where they really went in and consolidated a market, and it was an easy market, easier because there were some large multi-specialty physician group practices there, so they could go in and do that. I would say probably as you move from the West Coast to the East Coast, you've seen it obviously more on the West Coast. I think on the East Coast, generally speaking, it tends to be more community-based physicians, smaller groups, and it really depends on how competitive a market is among the provider community. So, for example, I went in and talked with Lakeland Hospital, and they're in St. Joseph's, Michigan. They're the only hospital in town. So we're going through our checklist and say, well, what about physician employment? They said, we don't need to employ the physicians. They don't have any place to go. So I think, you've seen that as a competitive response to align those physicians to get those admissions. I think, a lot of that's happened. I think, like you said, Sheryl, on the specialist side, they've kind of lined up those specialists. I think now it becomes a question of, well, how do we align them without employing them? IT is a great way to do that. Providing some of that back office business function to a physician group without actually employing them. So that way, what you're doing is you're aligning them with your organization, but you're not paying them and picking up their salaries. But hopefully you're going to get the downstream revenue from that.
Yeah. So Jim, you're suggesting that perhaps the trend might slow because hospitals are getting better at recognizing how they could at least achieve some of the integration without employing the physicians.
I think that, I don't know, I think it depends. I wouldn't be surprised to see it slow a bit, but again, I think in the East Coast, I think you're going to see probably there's some further consolidation happening there. I think the other question is what happens if hospital, on the not-for-profit side, if hospital margins start to get squeezed, will they be in a position where they want to take on those physicians? That becomes a big wild card.
So I agree with you. The driving force is volume, volume capture, and full beds make you money. Empty beds don't. The competitive dynamic of I need that group. I don't want my competitor to get it. Also, you know, what scares me about this is they're still losing money on those practices. That hasn't changed. So these guys never learn. And it's really frustrating because we've seen this play out badly for them before. So I'll say yet again, because I think I say this at every conference and at every opportunity, would you please learn from your past? You know, I'm not sure we even understand what the goal and aim is of owning the physicians. What's the strategic end game of owning the physician practices? If it's just simply to control your volumes and control your destiny, okay, I get it, then that's a cost of doing business, and maybe those losses, if you can minimize them, are acceptable. But if it's some notion of a risk-based plan that is not well, you know, formulated and sort of this nebulous thing out there, if there's really not that much competition, you shouldn't be owning the practice, I would agree, and those are going to unwind. The thing that the publicly traded hospitals tell us that really is driving this is physicians who are new graduates and physicians who've been around for a while want this. It's being driven as much by the physician and with great reluctance on the part of, I'd argue, arguably the smarter hospital systems who are employing these doctors reluctantly because it's the only way they can get their services.
Yeah, if I could jump in there, I do think that's a driving force are younger physicians who want shift work. They don't want to be on call 24/7, and they don't want the headaches of running a practice. They're looking for employment. So who employs hospitals is who's employing. We're not having a major expansion of multi-specialty group practices. We may see some. So I think that's going on. I just want to say, I've seen reports of 50% of docs now employed by hospitals or something. That's a wild exaggeration. I mean, the data, the better data is that I'm just reading from an AMA survey from 2012. 60% of docs are still in groups of 9 or less. 20% of those are solo. They're in independent practice. There is a move towards groupness. Docs can, a single specialty group that's a price taker is accepting a Medicare fee schedule or less, decides to consolidate to have more leverage on that price, or they, some of them can see that as a benefit of going to the hospital. But this is not quite the shift that it was portrayed. There was an early phenomenon, about 5 years ago, the phenomenon of cardiologists wanting to all move because of provider-based payment or cuts in their payments, and the fact that they were in a good bargaining position because of the substantially higher payments for the facility fee, but that's going to be corrected at some point. So I think there is a sort of a broad trend towards docs not wanting to be an independent practice, but I wouldn't exaggerate how much this is sort of happening.
Well, and I think you bring up a good point. The whole idea, we've seen some hospitals, and one of the offsets to employing the physician is the hospital-based billing on the ancillaries that helps offset that. And I think as that gets taken care of, that's going to reduce their, maybe that cost offset. And then also the whole idea of the SGR cuts, if that does go through, which I think is, they seem to pull it out from the fire at the last minute, but I think that becomes maybe a bigger risk given the current environment in Washington.
With, as very big ramifications for lots of other providers and some even elements of the hospital as well. So boy, it would not be fun, but it would keep us employed.
And just one final point to make to Sheryl's point about what did they learn from the 90s. What I learned from interviewing hospital people is they thought they were going to solve this problem the second time around by paying docs on RVUs generated on productivity rather than giving them a salary. And so that's what they think they're doing to try to get better performance. I was struck by the income. Well, I don't know if it's incompatible, but there's some dissonance between wanting to be a population-based ACO and bringing docs in and paying them on RVUs, and without sort of recognizing that dissonance. I mean, it was just like we're doing both things. So I have also heard that it's still not a sustainable business strategy to be doing a lot of employing. So I'm interested to hear that confirmed.
Yeah, so are they doing anything, besides getting volume? There's also this notion of, well, if we're going to integrate care, we'll have more control over the employed physicians.
Yeah.
but have they actually figured out a way of doing that?
Yeah, some of the hospital systems have. So, there are a couple of initiatives out there, maybe 3 or 4. You're trying to deal with evidence-based practices and changing the way people behave in the hospitals. First of all, you have to show them how they're actually behaving. So you actually have to give them the data and says, if you want to be high quality, low cost, all the way out on the right-hand side of the graph towards the bottom, where horizontal is quality and vertical is cost, you want to be to the right on the bottom. And if you give physicians the data, they're very competitive, and they are occasionally rational, so they understand you shouldn't be the guy who is doing a really bad job and costing them more besides paying more for the privilege. So that is actually going hospital by hospital, doctor by doctor. This is very, very time consuming. It's very difficult to drive this kind of change, but if you do, it really works. And the first place you see it is in supply costs. Because actually the easiest thing to change is to standardize on a set of supplies. Some of the harder things to change are technique. Okay, so you're still going to get variation in outcome because you have variation in people performing the services. But if you employ the physician, it is much easier to say to them, when you're the chief of the medical staff, if you come and practice in my hospital, you have to abide by these standards of care. And then having standards of care and having standard operating procedures, and this is one place where having the electronic health record, the clinical information system more precisely, that actually does help you go through that decision tree, does tend to standardize the care at a higher level. And you can affect change. It is much, much easier, especially if you think about it, where you're a very large organization like an HCA with well over 30,000 community-based physicians who are affiliated, and 5,000 at the time. This data is about a year old, and about 5,000 employed physicians. It's much hospitalists in particular. It's much easier to communicate changes in best practices to 5,000 people across 160 hospitals than it is to 32,000 people.
I think, Jim, you were going to...
Well, I was just going to say, I think that when we talk with a lot of hospital systems, they think that's a big area of cost efficiency, is taking out the variation, just like manufacturing. And I guess it remains to be seen, but intuitively, I think that it makes a lot of sense, and that's where the IT systems, clearly can make a difference in terms of those physician behaviors. Because before in the 90s, you'd go to a physician, he goes, well, I have sicker patients, and there's no way a hospital could come out and could determine that. And now they've got the empirical data to say, no, you don't. Yeah. And you're using up much more OR time, you're using much more supplies, and the results of the health profile of your patients isn't any better.
Right. So there is actually data from Tenet Healthcare that actually is spectacularly successful. They originally projected from the first 5 DRGs that they did this on the Big Five, they projected about $50 million a year in cost savings, and it's now well in excess of $80 million a year and still growing. And that's for the system as a whole.
That's good. The final question I wanted to ask, and then we'll go to the audience for questions, is what about the implications on payment rates from employment of physicians, in the sense that, how large is the bump that, is the higher rates that hospitals negotiate compared to what independent practices do? And does this have an effect on the rates for the hospital services as well?
So I would say that the notion of physicians being aggregated under the banner of a local hospital system that gets good rates is, in part, you do that as a physician organization. You sell your practice to the hospital, so you'll get higher rates. And that is a big motivating factor, because you are giving up your independence and, to some extent, your choice in how you practice medicine to join this organization, and you better get something out of it. And the something that you get is they're not the ones who have to do the negotiating. Okay, so they've outsourced that to their hospital parent. And when the hospital parent does it, they're doing it for many more physicians, and so theoretically, volume discounts should give volume premium should accrue to the hospital. That's the theory. I think it's hard in practice to get that. I think that the stickiness on some of the health plans, even where the hospital is dominant, is still very, very firm on the issue of the physician reimbursements.
Great, okay.
And let me just put a plug in. If you have a moment, please fill out your evaluations before you leave.
Where do you see the Medicare Advantage market being 2 to 3 years from now, once the toughest phase of cuts has gone through?
I'll take a stab at that. So I think what we will see first, on the membership side, definitely a very much slower rate of growth, but probably still some growth in the current open enrollment period. That's yet to be confirmed, but I think despite the fact that there have been some shaving to benefits, that there's been some narrowing of networks, the demand for Medicare Advantage is still there, and the value proposition to middle class and lower middle class seniors is absolutely there. It's harder to tell as we look ahead to going into 2015 because you've got a program that's already from 14 and reimbursement changes that occurred earlier. I wouldn't say stripped down to the bone, but it's been under a lot of pressure. And now your STAR demonstration program expires in 2015. Your industry fee goes up by more than 40%. You have the next and really the largest final raft of the reform benchmark phase-ins. And some other technical factors, what we don't know yet is what trend rate we're going to get from CMS in February that will be finalized in April. But all of this just to say there may be more significant cuts to benefits and maybe more plan cancellations, maybe, unveiled in October of next year going into 2015. So you could actually see an outright decline in Medicare Advantage enrollment, possibly. And then I think from there, probably you're going to return to pretty robust growth by 16, if maybe 17, because the payment transition will be mostly behind us, and the program should, in theory at least, then be growing by the Medicare rate of inflation. And of course, the big tailwind at that point is going to be the demographics, where the baby boom generation turning 65 peaks in 2021, I believe, and where that demographic is increasingly less likely, vanishingly less likely to have private sector employer-paid retiree supplemental coverage, certainly, and also more familiar with plan selection and managed care dynamics. But you'll have a lot of plan consolidation during that tough period in all likelihood.
And I'll just very quickly, so I've got industry's growing Medicare Advantage 10% this year. I'm assuming it's going to grow half of that in 2014 because of a lot of the changes that Matt mentioned. One thing that's been interesting to me is Humana, one of the largest Medicare plans, really not cutting benefits in 2014. Despite those rate cuts, much larger reliance on medical management savings than actually raising premiums and copays. I would argue a riskier strategy for them, but something that will help their membership growth. And just the broad point is, we've seen time and time and again, once somebody's in a Medicare Advantage plan, you can basically do anything you want to them, and they will not leave. When you cut benefits, it makes it harder to attract people out of the fee-for-service program into Medicare Advantage. But really, the only time you ever see somebody leave Medicare Advantage is when their plan exits and they don't have anywhere else to go.
Well, except for there's a small turnover, but that turnover is sicker. So people who leave Medicare Advantage plans, presumably because of a new illness or something, back into traditional Medicare, there is still a risk selection issue going on there.
Yeah, if you become institutionalized, you have to leave. So.
Have a question.
Question there? Sure.
James McGee from the Transit Employees Health and Welfare Plan again. Earlier you were talking about risk models, and our carrier is aggressively pushing patient-centered medical homes. And although we are convinced that, in theory, this is a good model, I think one of the panelists used the phrase about directing risk at bedside. And one of our questions is how this works in a multi-payer environment. How do these physician practices differentiate our carrier from the other carriers in terms of how they practice medicine? This is something that the carrier itself has not been able to demonstrate adequately to us. And I was wondering if you could comment.
That's a great question. Who would like to do it?
Yeah, I mean, it's CareFirst has spent a ton of time and money, doing. Is that who you were? I mean, and they seemingly have had some pretty good success with it. But we've talked before. Running a mixed model, seems to be a very, very difficult thing to do from a provider perspective, to be able to differentiate that, and use the data for a specific group of patients as opposed to a big change in the practice. So.
I mean, it almost argues for vertical integration of payer and provider in order to do that.
My comment would be that Medicare, a couple of the Medicare demos are trying to be multi-payer and have Medicare, Medicaid, and at least the significant commercial insurers all agree on sort of the approach to supporting the medical home. It's difficult. They're competitive organizations, those commercial payers, and often want to sort of disappear. So there's been mixed success, and Medicare is not also the greatest partner typically. In this one, they have actually been relatively good, but it is. But so you're absolutely right. The medical home wants consistency across all the providers. They want common sort of an assessment tool to certify that they're medical homes. They want common quality metrics. They would like to have all the payers. One of the positives that I've heard on my site visits is care coordination. They'd like the idea that there's some financial support for bringing in a nurse case manager to work with chronic care patients, but some of the payers are leaving. So it's ideal to move in that direction. It's hard to pull it off.
Yeah, just to add something that, in our complex system, you can have a carrier decides that they want to do this. But then, and so for their fully insured business, that's part of it. But then they still have to go employer by employer, like to you, and say, get their permission to pay this different way. And I spoke to one carrier who was saying it hasn't been a problem. But I'm sure that that's not always the case. We've run out of time. And I want to end by first thanking the panel, who I think done a phenomenal job. I want to thank the HSC staff for the work they've done to make this such a smooth operation, and thank the Jane Koskinas Ted Giovanna's Foundation for Health and Policy for sponsoring this conference.
And let me just add, I know Paul mentioned it at the beginning, there will be a webcast available from our website today that you can watch, and we'll have a transcript probably early next week.